Welcome everybody. My name is Giulio Sanasardo and I'm the project manager for the ERN-EuroBloodNet, the European Reference Network for Rare Rheumatological Diseases. It is my pleasure to welcome you on behalf of the EHA and the ERN-EuroBloodNet to the first session of the EHA and ERN-EuroBloodNet Spotlight on Hypereosinophilic (HES). That is an accredited European online educational program targeting health professionals organized by the EHA in collaboration with the ERN-EuroBloodNet. The program consists of a cycle of 4 webinars focused on EHS developed in collaboration with 2 experts, members of the EHA and the ERN-EuroBloodNet, Professor Massimo Breccia from Policlinico Umberto in Rome, Italy, and Professor Florence Roufosse with us today from the University Hospital of Brussels in Belgium. The main objective of this program is to disseminate up-to-date knowledge among interested hematologists, internists, pediatricians, and other healthcare providers to give visibility to cutting-edge advances in the field of HES. And before we start, let me share some home rules just for you to be aware. The program is accredited by the European Board of Accreditation in Hematology, and participants will receive 1 continuing medical education points when they take part in 1 online webinar. In order to do so, participants will have to take part to the webinar, of course, and answer to the satisfactory survey that you will receive at the end of the webinar. Also, please note that this session is being recorded and it will be uploaded in the EBN e-learning environment. So if you wish not to appear, please turn off your camera and change your name on the platform. Also, kindly be informed that your microphone is muted. And if you have any questions about the presentation, you can write them on the chat and they will be addressed, as you can see in the slide there, at the end of the session during the Q&A session. And you will find the chat at the bottom of the screen in that little cloud symbol. So as said, today is the first session and we're going to have a lecture on eosinophils, hypereosinophilia and hypereosinophilic syndromes provided by Professor Florence Roufosse. Dr. Roufosse is Professor of Medicine, Internist, and Clinical Immunologist at the HEB Hôpital Erasme in Brussels, and is the past president of the International Eosinophils Society. Furthermore, Dr. Roufosse conducts translational research to improve understanding and treatment of HES and contributes to international clinical trials, evaluating novel treatment options and biomarkers for HES and EGPA. And now, Florence, I'm going to leave the floor to you.
Thank you, Giulio. And thank you also for organizing this webinar series on hypereosinophilic syndromes, because it's really a very exciting time to be dealing with these disorders. I've been seeing patients with HES for the past 30 years, and I must say this is really a very, very nice era to have new patients, because we really truly have improved diagnostic pathways and most importantly, improved therapeutic advances for these patients. So I'm going to talk today, it's more of an introductory talk to really set the scene for the 3 following webinars, which are really going to be a deep dive into the pathogenesis and diagnosis and treatment of hypereosinophilic syndromes. But before that, I think it's really important that everyone be on page on what eosinophils are, what hypereosinophilia is, and then how hypereosinophilic syndromes are defined. So the learning objectives of this webinar are summarized on this slide, which I'm perhaps not going to go read in detail through. It's going to be available on the recording online. And I'm also going to rapidly show you my conflicts of interest, but which should not pose any particular problems for this webinar series. So my job today is, first of all, to introduce you to the eosinophil. It's a very, very nice cell. Eosin is an acidic dye, and the contents of the eosinophil are highly cationic. We're going to discuss these cationic proteins just in a couple slides. And this is really what confers to the eosinophil this very distinct staining aspect, and which makes it very, very avid for this acidic dye. It also has a bilobe nucleus. You can see it here on a blood smear. And also here you can really see very easily these beautiful eosinophils in the submucosal region in this very, very nice biopsy specimen. So eosinophils are myeloid cells. They begin their life in the bone marrow, where they're going to progressively differentiate, mature, proliferate in response to a series of, to a program with successive transcription factors and growth factors, one of which is really important, and we'll talk about a bit more later, which is interleukin-5. It's a relatively specific cytokine for the eosinophilic lineage. Once eosinophils have matured in the marrow, they're going to leave the marrow and enter the circulation, where the majority of eosinophils will really not spend much time. It's considered that roughly 1% of the total pool of eosinophils in the body are actually found in the blood, whereas the remaining 99% are found in tissue. And in healthy subjects who do not have eosinophilic disorders, these are the tissues at the bottom of the slide where you will find eosinophils. If you look at the whole pool of eosinophils, really by far the majority of eosinophils in the healthy subjects are contained in the gastrointestinal tract, with the exception of the esophagus, where you do not see any eosinophils in healthy conditions. But as you can see here, there are also eosinophils in various other tissues. And in some of these tissues, we're beginning to have an idea of what the eosinophils are doing, mostly in mice. We have very, very little knowledge of what homeostatic eosinophils actually do in tissues in humans. Eosinophils are very, very interesting cells in that they produce many different substances. We're going to speak about that a bit later, but they also have many, many different receptors. And depending on what receptors are engaged on their surface, eosinophils will adopt very different behaviors. They will release different substances. So their behavior is very much impacted by their microenvironment. And then they also have the ability, obviously, to impact their microenvironment as well. Among these receptors, you will recognize receptors which are typical for innate immune cells, and these are granulocytes, so they are part of the innate immune response. And you can see that they have receptors for a series of immunoglobulins. The IgA and the IgG type immunoglobulins are important activators for eosinophils. There is still some controversy about their expression of high affinity receptors for IgE type immunoglobulins. They also express pattern recognition receptors, which enable them to react quickly to invasion by pathogens, and complement receptors. They also express a series of receptors which are really important for trafficking to tissues, adhesion receptors, of course, but also a series of receptors for chemokines, some of which are really quite unique to eosinophils. Like, for example, CCR3, this is a very, very important receptor in eosinophil biology, but you can see that there are others which are important as well. And then finally, they have receptors for a series of lipid mediators, which are produced locally, and they have receptors for cytokine and growth factors. And we'll come back to IL-5, as I said earlier, but the IL-5 receptor alpha chain is pretty specifically expressed by eosinophils, at least at high levels in humans. I said that IL-5 was really important in eosinophil development and functions, and this is actually well illustrated on this slide. So you know that IL-5, one of the important sources of IL-5 in humans and in other animals, by the way, is the Th2 cell, so the helper T cell. But you also have an important source, which is more local in the mucosal interface with the environment, which are the ILC2 cells. These cells produce IL-5, which will have a series of effects on eosinophils. I already presented the effects on eosinophil poiesis, which is really important, but IL-5 is also going to synergize with chemokines to attract eosinophils to tissue. IL-5 will also be important for eosinophil activation. And finally, when IL-5 is present in the environment, eosinophils will survive longer. Eosinophils are cells which tend to die pretty rapidly. And if you have these growth-promoting cytokines, including IL-5, in their environment, this will prolong their survival. I said that the eosinophils were also very complex cells in terms of the mediators that they produced. I'm not going to detail everything here, but I'd just like to re-insist on these highly cationic proteins: major basic protein, eosinophil peroxidase, eosinophil cationic protein, in eosinophil-derived neurotoxin. These different proteins have extremely cytotoxic effects in the environment when they're released by the eosinophil. They also have some other interesting effects, but I'm not going to go into much detail about that. Another important type of substance which will be released by eosinophils upon their activation are derived from the arachidonic acid, which is found in the lipid membrane. So these are leukotrienes, prostaglandins, for example, which are also going to impact cells in the environment, favoring, for example, vasodilatation, bronchoconstriction, let's say leaking of fluid from capillaries, etc. Eosinophils also produce, as you can see here, a series of cytokines and growth factors themselves, and also a series of chemokines. They also, just like neutrophils, are able to produce a respiratory burst and produce reactive oxygen species, which are obviously going to also have a cytotoxic effect in their environment when they're activated. There's also a very interesting molecule which is quite unique to eosinophils, which is galectin-10, which is found in the cytoplasm, and when it's released in the milieu, it's going to crystallize to form what's called Charcot-Leyden crystals. And these crystals are also important in mediating some of the cytotoxic effects and other effects that eosinophils will have when they're released in a tissue. So historically, what do eosinophils do? There was the way they were found to act and to behave as effector cells in the past, and now our knowledge is really evolving very, very rapidly. So historically, it was quite logical that hypereosinophilia was observed in patients who have helminthic infections, and you can really see here by the size of this larvae that it's going to be impossible to get rid of this kind of pathogen by phagocytosis. So what you need is a highly cytotoxic cell, which is going to recognize this pathogen in an antigen-specific manner through antibodies and expression of the receptors for these antibodies, which is then going to activate the eosinophil, which is going to release these highly cytotoxic mediators on the surface of the parasite and destroy it. This is really the initial thinking about how eosinophils function relative to helminthic infections. We now know that it's a lot more subtle than that, and depending on the type of helminth, whether it's a primary or a secondary infection, the behavior of eosinophils is actually quite different with respect to favoring destruction of parasites, or quite to the contrary, favoring their survival. It's also been known for a long time that in parallel with these beneficial effects for the host, eosinophils have deleterious effects. And this has been known for many, many years now, that they are actually able to damage tissue in allergic reactions. And this was well demonstrated in asthma many, many years ago. What you see here on the top is an intact bronchial epithelium from a healthy subject. And you can see that the eosinophils here, they're stained in brown because this is a stain for eosinophil cationic protein. There are not many eosinophils, and they're pretty deep within the epithelium here, beneath the mucosal surface. Whereas in patients who have severe asthma, and this is an example, I think it's an autopsy study, if I'm not mistaken, you can see that the number of eosinophils is multiplied considerably, that they're much closer to the epithelial surface, and they've caused extreme damage and disorganization of this very, very, I'd say, chaotic epithelial surface. And this is due to their cytotoxic effects. So for a very long period of time, it was really thought that basically eosinophils were effector cells with strong cytotoxic effects, which was obviously just part of the truth. We now know in asthma that eosinophils have a lot more interesting and subtle roles besides just cytotoxicity. And for example, eosinophils contribute to deposition of extracellular matrix proteins and remodeling. And we know that remodeling is a really important feature of asthma, which contributes to long-term damage of the airways in patients who have uncontrolled asthma for many years. So what you see here in green is the deposition of tenascin, which is an extracellular matrix protein, in a healthy controlled bronchial mucosa. You can see that there's a very, very dense staining pattern for this tenascin in an asthmatic patient. And if you treat a patient with anti-IL-5 antibodies, and we're going to talk about that later on in the webinar series, you will deplete the eosinophils in blood completely, and considerably so in tissue. And in parallel, you can see a very, very significant reduction in the thickness and the density of tenascin deposition. So clearly, eosinophils directly contribute to this ECM protein deposition and remodeling. It's also known that, quite similar actually to what neutrophils have been known to do for a while, eosinophils are able to extrude extracellular DNA in the form of what's called traps, extracellular traps. Instead of netosis, it's called etosis. And this is actually what happens when eosinophils are going to die by cytolytic death. They're really going to expulse the genetic material. And this DNA, this extracellular DNA, is known to be extremely adhesive and is able to entrap pathogens, and including, as you can see here, bacteria and fungal pathogens. And so, not only parasites are going to be handled by eosinophils, but also other types of pathogens. And this is, amongst others, due to the fact that these extracellular traps are very, very closely linked to intact granule proteins. So these granules are really interspersed and intermixed with the DNA and are going to be able to have a life of their own. Besides the healthy eosinophil, which is intact, these granule proteins continue to be able to exert their cytotoxic properties. So this is really interesting and new data on how eosinophils can be cytotoxic. So nowadays, we see the roles of eosinophils in asthma quite differently. Besides the cytotoxic effects that were well known, which can cause cell damage, we now know that they play an important role in airway remodeling, but also because of these extracellular traps, which are very sticky, sarcollatin crystals, which are also extremely sticky, they're responsible for the mucus plugging, which is typical of severe asthma, and which actually still remains a cause of death of asthma attacks. So these are the deleterious effects which have been mostly studied in asthma, which is a pretty common disease. We're going to be talking during this webinar series about hypereosinophilic syndrome, and I'm just going to introduce what toxic eosinophils can do besides damaging the airways in asthmatic patients with this first slide, which is an old study, but it's really, I find, quite beautiful, where what you see here is actually the endothelial surface of the papillary muscle of a heart from a cat. So you can see these beautiful endothelial cells, each one separated by an intercellular space right here. And if you incubate this endothelial surface with supernatants from healthy eosinophils, from a healthy subject, meaning that these are not activated eosinophils, there are small numbers of eosinophils and they're not in an activated state, you can see that the endothelial surface remains quite healthy. Whereas if you take eosinophils from a patient with hypereosinophilic syndrome, and you either make these eosinophils, you make them in direct contact with the endothelial surface, or you take their supernatant and you put it on contact with the endothelial surface, you can see here all the damage that is being done. This is really an illustration by electronic microscopy of how cytotoxic the eosinophils can be on this endothelial surface. And this actually translates into human disease by the different complications, and we're going to go into more detail about this a bit later on, that are known complications of hypereosinophilia in patients with hypereosinophilic syndrome. You see here the different phases of cardiac damage in patients who have persistently elevated, activated eosinophils in their blood. The first stage is subendocardial infiltration by these activated eosinophils. So they're really between the endothelial surface and the myocardium itself. And they're going to release all their cytotoxic substances, but also a series of cytokines, including TGF-beta, which has pro-fibrotic effects. And if this inflammation is not controlled pretty rapidly, this will eventually progress to subendocardial fibrosis, causing a restrictive cardiomyopathy, which is absolutely not reversible. In addition to that, the presence of these eosinophils, which are activated just under and below and in contact with the endothelial cells, are going to make these endothelial cells express tissue factor and facilitate intravascular coagulation. And eosinophils, there's no time to go into any detail on that, but they actually favor a series of effects, which are going to favor formation of intravascular thrombi. So you can see here an enormous thrombus in the left ventricle in a patient with hypereosinophilic syndrome. This is also a common complication in the apex of the heart. And you can also see here the possibility of arterial occlusion, and this is also potentially due to direct cytotoxic effects of activated eosinophils on the endothelial surface. So nowadays, the different ways that eosinophils contribute to health and to disease have really progressed a lot compared to what we used to know, just related to their effects in asthma and on parasitic infections. I talked a bit about cytotoxicity, remodeling, and fibrosis. I'm not going to mention that anymore. But eosinophils also are they're true actors in the inflammation and the immune response, and they're able to interact with other cell types in the immune response. They contribute, for example, to plasma cell survival in the niches in the bone marrow. They also will act on T cell activation and on the polarization state, depending on what they're going to release in terms of cytokines and growth factors. And they also can interact with numerous other immune and non-immune cell types, for example, on nerve endings. And this has been really beautifully demonstrated in the lungs, for example, in asthmatic subjects. In addition to that, eosinophils play roles in development and homeostasis. And just to give a few examples, they're involved in fat beiging through their production of IL-4 and IL-13, which is going to impact local macrophage polarization, but also in development of a series of tissues, including the mammary gland. And just to give you one example, so I'd just like to say, this is a disclaimer, is so far, we only know what we know about the role of eosinophils in homeostasis is mainly derived from neuron studies. So I think it's really important just to know that what I'm presenting here is related to mice so far. And obviously there's a lot of interest for the impact of eosinophils in homeostasis in humans. And that's really a topic of many, many studies for the time being. Obviously more difficult to study in humans than in mice, though. So now, just as I said, I was just going to give you one illustration of the role of eosinophils in the healthy gastrointestinal tract. We don't know much about what happens in humans. What we do know for sure is that there are lots of eosinophils in the healthy gastrointestinal tract. I already mentioned that very, very early in the talk. And as you can see, the number of eosinophils progressively increases to achieve a maximum count in the cecum. Then it goes back down towards the rectum. And these are the numbers of gastrointestinal eosinophils that are found in children who complain of stomach pain or abdominal pain, in whom no underlying diagnosis is eventually made by endoscopy. And in mice, the role of eosinophils is now being actively studied in the GI tract. They are present before birth and before the colonization by the microbiota. And their presence clearly plays a role in uptake of lipids, but also in the formation, the healthy formation of the villi. They contribute to let's say, regulating intestinal contractility, and they also interact with local cell types. And this has been studied, obviously, in mice who are knocked out for eosinophils and in whom the gastrointestinal tract development is faulty. And so this particular article really underlined the critical role for eosinophils in facilitating the mutualistic interactions between the host and the microbiota. So now that was really setting the scene about eosinophils, how they function, and their different roles in health and, let's say, disease. Now, what is hypereosinophilia? Hypereosinophilia can be defined in the blood and in tissue. In blood, it's pretty straightforward. One can speak of hypereosinophilia when there are more than 1,500 per microliter. Between the norm, which is below 0.5, and hypereosinophilia, we can talk about eosinophilia. And this is typically the level of eosinophil counts that you will see, for example, in severe atopic presentations, such as severe eosinophilic asthma. Hypereosinophilia is really when you've more than 1,500. Hypereosinophilia in tissue is a bit more difficult to define. It's more subjective. It's like the pathologist is going to say, oh, I have the feeling there are more eosinophils in this tissue than what would be expected normally on a biopsy. And even more subjective, or let's say more difficult to really ascertain, is if you don't see eosinophils, but in their place, you can see deposition of eosinophil granule proteins. This means that eosinophils have been there and that they've degranulated, and now you can't see them anymore, because to be able to see them, you have to still have intact granules in their cytoplasm, because that's what's going to make them stain with eosin. So if they're really very activated, sometimes you can miss them with a hematoxylin eosin stain. And so being able to demonstrate their presence indirectly through the demonstration of eosinophil granule protein deposition is the equivalent of saying this tissue is infiltrated by eosinophils, or recently has been at the very least. And I just wanted to illustrate that because I think it's an important concept with this slide showing these are myocardial biopsies, which barely showed any eosinophils on these different surfaces, which are shown here. You can see here an enlargement of this region. But if you stain for MBP, major basic protein, you can see massive deposition of these granule proteins. And this is really considered a surrogate for the presence of eosinophils, either still in tissue but completely degranulated and therefore no longer recognizable as such, or eventually their recent presence in tissues and now they're all died of their cytolytic death. Moving along now to the most common causes of hypereosinophilia, because I think it's important to mention this, even if we're going to talk about hypereosinophilic syndromes mostly. They're really summarized on this slide. Most common disorders are allergic disorders, parasitic infections, and cancer. Atopy, as I said, is rarely associated with hypereosinophilia. It's mostly associated with eosinophilia. Although some patients who have severe eosinophilic asthma, sometimes they do go above that 1.5 giga per liter threshold. But mostly, in terms of allergy, what you see is really severe adverse drug reactions. For example, DRESS, which is drug reaction or drug-related eosinophilia, or drug rash with eosinophilia and systemic symptoms. These are really the most common causes in our countries of hypereosinophilia. In other countries, it's helminthiasis. I've already discussed this briefly, and also ectoparasites, which should not be forgotten, namely scabies, which is still something that we can see in the clinic. We regularly have patients here in Brussels who have scabies, and diagnosis has become difficult because people wash. And so the clinical presentation is sometimes not that obvious. And then obviously a series of neoplasms. These can be hematological malignancies, but also solid tumors, and more specifically, more commonly, let's say, adenocarcinomas. The most commonly responsible drugs for hypereosinophilia are antibiotics, but also anti-epileptic drugs. If you see a patient who has hypereosinophilia and antibiotics of the family of penicillins or one of these anti-epileptics, you can immediately make a link between the two and suspect that this patient has a drug-induced hypereosinophilia. Also, because it's really prescribed quite a bit, allopurinol is certainly another medication which you should be very suspicious of in a patient with a hypereosinophilia. So I just went through the most common etiologies of hypereosinophilia: allergic disorders, drug hypersensitivity, infections, neoplasms. And then besides that, there is a series of less common disorders, like, for example, different forms of immunodeficiency, primary immunodeficiencies, which are responsible for hypereosinophilia. We're not going to discuss that today. We're going to be discussing these rare eosinophilic disorders, such as idiopathic hypereosinophilic syndrome. And eventually, if someone is more interested, perhaps when we get further along in the webinar series, we can discuss EGPA briefly. But this webinar series is really, really mostly about hypereosinophilic syndrome. And so basically, to kind of summarize that, I think it's Peter Weller who said one day that hypereosinophilia can be summarized by wheezes, worms, and weird diseases. And we're going to be talking about one of these weird diseases. How is a hypereosinophilic syndrome defined? So you have to have hypereosinophilia, that's important. But to have a hypereosinophilic syndrome, you have to have the criteria for blood and tissue hypereosinophilia. So both have to be observed. In addition to that, you have to have organ damage and dysfunction, which are directly related to the presence of eosinophils in the tissue. And the different types of organ damage and dysfunction are summarized on this slide. And I'm not going to go into a great level of detail on these different complications of chronic hypereosinophilia, but one thing for sure, I think you can really see that as a glance, is that there are practically no organ systems which are spared by the complications that can potentially arise in a patient with hypereosinophilia. I have circled in blue the different systems which are most commonly affected. So this is the lungs, the GI tract, and the skin. But in addition to that, it's important to be aware that cardiac manifestations, although less common, are those that are most severe. And I already illustrated that with the thrombus formation, the subendocardial fibrosis. You can also have valvular entrapment and even rupture of valves, etc. So these are really, really preoccupying complications of hypereosinophilic disorders. And this is just one study which examined all causes of death in patients who had hypereosinophilic syndrome. This is from the Mayo Clinic series. You can see that many patients were studied, and among them there were 15 patients with deaths. And if you look at cardiac dysfunction, plus vascular disease, plus thromboembolic events, you can see that this accounts for more than 50% of the causes of mortality, and also obviously important morbidity. Prevalence of end organ damage, as I said, the most common complications, the skin, lungs, and GI tract. This is a very, very nice multi-center retrospective study, which was conducted in 11 different centers, collecting information retrospectively for almost 200 patients. A very nice representation of different clinical subspecialties, although probably hematologists were underrepresented in this study. And what you can see is whether it be the initial clinical presentation or the subsequent, accrual of damage, you can see that all of these different organ systems can be affected, and the cardiac complications that I mentioned occur about in 1 out of every 5 patients. I'd also just like to mention organ-restricted hypereosinophilic syndrome. This is actually tissue or organ-restricted disease where the blood criteria is not fulfilled, but otherwise the other criteria are fulfilled. So you have tissue hypereosinophilia and damage, which is directly due to the presence of eosinophils. And one example of that is chronic eosinophilic pneumonia, where you can really have recurrent episodes of breathlessness, sometimes with fever and night sweats, etc. These patients feel very, very unwell. They have condensations, ground glass opacities, generally which are migratory and peripheral. Their bowel fluid is actually absolutely packed with eosinophils. They have intraalveolar and interstitial eosinophils. And these patients, they'll be treated with the corticosteroids. They will spawn very, very rapidly, and then you will taper down treatment, and disease will recur exactly in the same way and in the same tissue. Someone seems to be drawing on the slides. I don't know who, but perhaps you can disactivate your editing capacities or something like that. It's not me. So pathogenesis of hypereosinophilia and hypereosinophilic syndrome. What are the different mechanisms? These mechanisms are going to be detailed in the 2 next webinars, but I'd like to give an overview of the mechanisms which will lead to hypereosinophilia in hypereosinophilic syndrome. One first mechanism is a somatic mutation, which will drive clonal eosinophil expansion, which can occur, for example, in a hematopoietic stem cell. Another mechanism is the increased presence of an eosinophilipoietic factor, which is going to drive polyclonal eosinophil expansion in the bone marrow, namely interleukin 5. Very, very uncommon cause, but it's part of the classification, is familial hypereosinophilia. So these are patients which inherit a polymorphism on a gene, which will facilitate the outgrowth of eosinophils. The exact gene has not been identified as far as I know so far, but it has been mapped, and it's very, very close and around the cytokine gene cluster, which is responsible for the production of IL-5, et cetera, and IL-3 and the other cytokines, which are important for type 2 immune responses. And finally, and unfortunately, the pathogenesis is unknown in the majority of cases of hypereosinophilic syndrome. So this is called idiopathic hypereosinophilic syndrome. Just to give a little overview, and as I said, there will be much more detail, which is going to be given in the next 2 webinars. So we can classify patients with hypereosinophilic syndrome in 2 distinct ways. First, on the basis of pathogenic mechanisms of eosinophil expansion, basically either myeloid or lymphoid variant disease, depending on whether the eosinophils are clonal or secondary to polyclonal expansion because of the presence of a growth factor. And as I said, the majority of patients, the mechanisms are unknown. This is called idiopathic hypereosinophilic syndrome. You will also see another classification system, and sometimes the 2 are kind of mixed in different presentations, where it depends really on the clinical presentation. Some patients with hypereosinophilic syndrome have a multi-organic presentation, a combination of different complications, for example, hypercoagulation state plus lungs plus GI tract. Others will have, for example, the kidneys and the skin or whatever. I already presented to you the tissue-restricted or organ-restricted disease forms, and some of these patients have eosinophils well above 1,500 per microliter, and so they will be classified as hypereosinophilic syndrome, but it's restricted to a certain tissue. And some patients who have chronic eosinophilic pneumonia will present this way. And then, for example, there are more specific and really recurrent and characteristic disease presentations. For example, so-called Gleich syndrome, where patients have episodic flares of angioedema associated with cycling hypereosinophilia, generally associated with fever, muscle pain, and high serum IgM levels. And these two classification systems really overlap. And you can really draw arrows between all of these boxes. So lymphoid variant will eventually present with organ-restricted, multi-organ, or Gleich syndrome. Same thing if you look at the other way around. If you have a patient with organ-restricted disease, he may well have lymphoid variant disease, he may well have idiopathic, and he may well have myeloid variant hypereosinophilic syndrome. So these are really two different classification systems. Some of these arrows are a bit thicker because, for example, lymphoid variant hypereosinophilic syndrome seems to be the main disease form, the pathogenic disease form, which is driving Gleich syndrome in the majority of cases. I'd like to end with another notion, which I think is really important, which is called hypereosinophilia of undetermined significance. So far, I've shown all the complications of hypereosinophilic syndrome in patients who have persistent hypereosinophilia. But some patients have unexplained hypereosinophilia, which is clearly persistent, but you can try as you may, you will never find a clinical complication of disease. And there are two case series which have been published several years ago now, roughly 10 years ago, which tried to figure out, were the eosinophils different in these patients compared to eosinophils with patients with hypereosinophilic syndrome? So this is the hypereosinophilia of undetermined significance cohort, and this is the HES cohort. And one thing for sure is that these eosinophils do not appear to be less activated in terms of the classical activation markers, which can be expressed by eosinophils. But I think we now have a lot better tools to be able to really understand better eosinophil functions in humans. So maybe if we perform this type of study nowadays with large cohorts of patients, we will be able to find differences, functional differences between these eosinophils. So it's really important just to underline that the recommendations for these patients is not to treat their blood test. You're not going to treat them just for the pleasure of seeing eosinophils normalize in their blood test. These patients are not ill, and for one reason or the other, their eosinophils are not accessing their tissues and they're not making them sick. So you're not going to make them sick with your treatment. But you do have to follow them up closely to make sure that they're not developing complications. And two last slides, I'd just really like to insist on the fact that these eosinophilic disorders, these hypereosinophilic syndromes, these are rare disorders, and like all rare diseases, their diagnosis is often delayed. I showed the average delay for rare disease, and hypereosinophilic syndromes are no exception. You see, it's more or less the same kind of delay in the majority of the diseases. And there haven't been many studies which have really focused on this so far in hypereosinophilic syndrome, but there has been one in gastrointestinal forms of hypereosinophilia. And what you can see here is a mean diagnosis of about 4 years. Patients develop their symptoms. It takes them a while to get to see a gastroenterologist. It takes a while for the gastroenterologist to eventually do the endoscopy, which is going to show the presence of eosinophils. But before the true diagnosis is actually made, there's going to be an additional practically 2 years, which are going to pass before the diagnosis is actually reached and a treatment is given. And the consequences of diagnostic delay are really quite deleterious. First of all, because as I showed you, these eosinophils are extremely toxic. They are both cytotoxic and profibrotic. And so you're going to be accumulating damage with time if you're not treating the hypereosinophilia, and you're going to be seeing disease-related morbidity and death. Same thing, because when you see eosinophils, even if you don't know what disease is behind that, you're often going to be tempted to give corticosteroid treatment. This is typically something which we're very comfortable with. Eosinophil counts go down very, very rapidly, but this is not targeted treatment. This is also very toxic treatment. And so patients are going to be accruing treatment-related morbidity as well. And this is just one example. This is the tip of the iceberg of what you can see in terms of corticosteroid morbidity and mortality. But there, as you know, there are many, many different side effects of prolonged corticosteroid use. And then obviously the fact of having a chronic inflammatory disease with no diagnosis, with no label, favors anxiety, depression, rejection, social and professional withdrawal. We all are very, very familiar with this in the realm of rare diseases. So I'm going to end with these take-home messages. I think they really more or less summarize all that I've said. I just really pinpoint one or two messages: that eosinophils, when they're persistently elevated, they are cytotoxic. They can potentially cause damage, dysfunction in various tissues. They can also cause irreversible fibrotic damage. This can contribute to morbidity and mortality. And we really want to reach a diagnosis and initiate treatment early to be able to prevent this irreversible damage. And for this, it's really important to increase awareness about this syndrome. And that's what this webinar series is all about. So if you want to learn more about these different disease variants and then the practical approach to how to diagnose and to treat these patients, I've put here the different dates for the following webinars. I'd like to thank you for your attention. We have time now for questions, I think, the 15 minutes that were normally programmed.
Thank you very much, Florence. Indeed, you have been very on point with the timing. And if I may, I will start reading the questions from the chat. We have the first question from Prasant, who asks how to differentiate monoclonal hypereosinophilia from reactive causes.
Okay, so that's going to be something which is really going to be approached in the following webinars, I'd say. So the answer could be very long. I could also make it pretty short. The first message, I think, is that it's very difficult to be able to distinguish them morphologically. So typically a patient, for example, who has a chronic eosinophilic leukemia of certain variants, at least, with very, very mature cells, these cells do not appear different if you're going to do a cytospin, for example, and if you're going to do, obviously, a blood count, a complete blood count with a differential. They're just going to appear in the eosinophil window as would be expected. So obviously you have to go further. You have to do cytogenetic testing, which we're going to be talking a lot about. Sometimes there are clues. This is something which I'm going to approach in the very, very last webinar. There can be clues in routine blood tests. For example, if you have an elevated serum vitamin B12 level, which is more commonly found in myeloproliferative disorders. But as you know, this is not necessarily specific to myeloproliferative disorders. If you have a splenic enlargement, this is also a clue. I'd say that practically speaking, empirically speaking, another interesting clue is these are the clonal disorders are the rare disorders where if you give corticosteroids, you're not necessarily going to see the expected decline in blood eosinophil counts. Reactive hypereosinophilia is generally nicely reactive to corticosteroid treatment as well. Which is not the case of clonal hypereosinophilia quite often. And so that can be an interesting clinical clue. But to really answer the question in detail, I think in itself, it's going to be worthwhile seeing what these different disease variants are with clonal and non-clonal eosinophilia, and then finally approaching what is the practical approach to patients to be able to tease out which ones have clonal and non-clonal disease. I hope that's a satisfactory response for now. Yeah, I'd also perhaps just like to say regarding the corticosteroids is that although reactive hypereosinophilia does respond generally very well to corticosteroid treatment, if the drive for hypereosinophilia is really, really strong, which you can see, for example, in DRESS, sometimes at the beginning of the DRESS, once the eosinophilic response has started, it's like an explosion. And you can give really high corticosteroid doses for a couple of days and not see eosinophils go down. But that is really quite typical in very, very strong adverse drug reactions. So that should not make you suspect necessarily a clonal eosinophilic disease.
Okay. Thank you, Florence. And now to the next question, which is by Giovanni. What panel of lab tests and/or imaging do you suggest for a follow-up of unexplained chronic eosinophilia?
Okay, so once again, this is a webinar series. So I obviously am not going to answer anything now so that you come back for the following webinars. But there's a series of tests. You have two parallel approaches to management of a persistently hypereosinophilic patient. You have to think about the different tests to perform for the eventually identifying underlying etiology. And at the same time, you have to look for damage due to eosinophils, because sometimes it goes really, really rapidly. This damage. So what are you going to do on one side? So the side trying to figure out where these eosinophils are coming from, why they're increased. Obviously, depending on the epidemiology, where the patient is from, where he has traveled, you have to look in priority for a parasitic infection. There are parasites which you can catch in Belgium, in my country, without ever having left the territory. So you have to know your parasites a bit. If you don't know your parasites, it's not a problem. You have to know your parasitologist and say, okay, this is a patient who has traveled here, or this is a patient who has never left this country, and he has hypereosinophilia. Could you please run the parasitic serologies which you think are appropriate in this particular instance? In parallel with the serologies, for certain parasites, you can find the eggs and the larvae in the stool sample. So you have to do that in parallel. Obviously, a very, very thorough drug history is important as well, including, the timing of introduction of drugs, trying to find, it's really kind of detective work, trying to find when each drug was introduced compared to when eosinophils first appeared in blood tests. Sometimes you just don't have these ancient blood tests, so you have to stop certain drugs to see if the hypereosinophilia is going to disappear. There's actually no agreement on how long it takes for drug-induced hypereosinophilia to regress. So you have to wait several weeks before saying, okay, this is not drug-induced hypereosinophilia, but there's no agreement on how many weeks that is. Certainly 10 days is not sufficient. So that's also a mistake which is commonly made. Then you have to think about cancer. Third most common cause. Does this patient have a hematological malignancy? Does he have a solid tumor? So you have to go through the risk factors for lung cancer, for colon carcinoma, etc. So all of these different investigations are going to depend on your level of suspicion of one of these cancers. You can do thoraco-abdominal and pelvic CT scans, or eventually a PET scan. Obviously, among these cancers, there's lymphoma. So, there's the patient history. Does he have night sweats? Has he lost weight? Does he have enlarged lymph nodes? There are those that you can touch, but obviously those which are found in the internal organs and close to them. So that's why you have to do these CT scans in addition. And then, as I said, there's also the consequences of hypereosinophilia. So does this patient have occult cardiac involvement? I say that that's the most important thing to rule out. So you're going to do serum troponin. You're going to do an echocardiogram, and eventually even cardiac MRI, which is more sensitive for finding eosinophilic inflammation in the subendocardial space. But, once again, as I said, this is going to be the fourth webinar. There's really going to be a detail, because I just mentioned a few things which I think are important to mention up front based on what I said today, but there are also a series of other blood tests which are going to be interesting to help figure out what kind of hypereosinophilic syndrome a given patient has.
Okay, thank you, Florence, again. And to the next question by Esta Brack. How often do we find charcoal-laden crystals in tissues, eosinophilia or hypereosinophilia, and what is their clinical significance?
Okay, so that's an interesting question. To the first part, how often, I don't have a clue. I really don't know. And I'm not sure someone could answer that question. But they do have a clinical significance. And like, for example, as I said, for the extracellular deposition of granule proteins, when I showed you that myocardial tissue where you could see no intact eosinophils, but you could see these proteins, it's kind of the same message. If you do gastrointestinal biopsies, and you can't see an excess of eosinophils, it could be because they're so activated that they've degranulated. And if you find charcoal-laden crystals in a body fluid like stool specimens, for sure, eosinophils have been there and they've degranulated. And I've had this once in a patient who had intestinal invasion by a helminth, someone who had traveled to, I don't remember which country in Africa, if I'm not mistaken, but who had very, very marked hypereosinophilia, and his stools were really packed with charcoal-laden crystals. Although intestinal biopsies had not revealed anything particular, he had intestinal complaints, and diagnosis of parasitic infection was actually ultimately made on the basis of positive serology. So, I mean, certainly something, if they're there, there's no other possible source than activated eosinophils.
Thank you again, Florence. Now to the next question from Eidos. What further follow-up is required in a patient with hypereosinophilia and ANA-ENA screening rates? And does this indicate some kind of autoimmune-associated eosinophilia? And what disease should be excluded if lupus, Sjögren's syndrome, scleroderma, and poliomyelitis have already been eliminated?
Okay, so you know that anti-nuclear antibodies are, they have this horribly elevated false positive rate, increased in females, increasing with age, increasing with chronic inflammation. So I would see that really as a kind of bystander, non-specific sign of inflammation in general. You can see this in chronic infections as well. So I would not take that into account. There are actually none of the connectivitis that you just mentioned are associated with hypereosinophilia. Really not. There's some potential association with rheumatoid arthritis. You know, some patients do have slightly elevated eosinophil counts, and sometimes even really a small minority really have extremely elevated eosinophil counts. And in the pool of patients with hypereosinophilic syndrome, you do get some patients with rheumatoid arthritis. So they might be a kind of link there between these illnesses, which is a very loose link. Let's be clear. So if you have articular pain in a patient who has ANA, I'd perhaps go further along the line towards making sure that they don't have clinical complaints which are compatible with rheumatoid arthritis. Eventually, anti-CCP antibodies and rheumatoid factor, but truly the only kind of systemic autoimmune conditions that you have to think about in a patient who has hypereosinophilia is EGPA. And that's why I said that perhaps we could discuss that at some point during the webinar series. This is not truly a hypereosinophilic syndrome per se, but I just participated in a vasculitis workshop in Barcelona where I was in a debate about whether idiopathic hypereosinophilic syndrome and ANCA-negative EGPA, are they the same disease or are they different? There's a kind of tricky overlap between these diseases. But besides that very specific circumstance, so EGPA, meaning eosinophilic granulomatosis with polyangiitis, the typical autoimmune disorders are not associated with hypereosinophilia. There are some. I mean, I'm just going to finish once again. There are exceptions. Bullous pemphigoid, that's autoimmune, and that's typically associated with hypereosinophilia, but not Sjögren's, lupus, etc.
Thank you again, Florence. Just to let everybody know that we are 5 minutes short of the meeting, so we will try and go on with the questions, but we won't be able to answer them all, unfortunately. And on to the next question by Mariami. Is it important to do tissues biopsy to exclude end organ damage in non-symptomatic patients with persistent eosinophilia?
Okay, so if that's non-symptomatic, that's pretty aggressive. As usual, there's always the benefit and the damage that we can do. So if truly the patient is asymptomatic, in parallel with that, there's no elevation in liver enzymes, there's no perturbed kidney function, etc. So you have to make sure with your physical exam, with your history taking of symptoms and signs, but also perhaps with the routine blood chemistry, that there's really no perturbations. This patient has normal other cell counts, nothing wrong with any of the organs that can be more or less evaluated with routine chemistry. If all that is normal, biopsies are not recommended. If I would say the only organ that you should be preoccupied about is the heart, because the initial stages are asymptomatic. And so obviously you're not going to biopsy a heart in an asymptomatic hypereosinophilic patient, but what you'll do for sure is serum troponin and a cardiac MRI, because that's what's going to be the most sensitive to detect damage in that very, very precious organ.
Thank you again, Florence. Now on to the next question by Olga. Could be a pathology persistent number of eosinophils 0 in PB?
So is PB bullous pemphigoid? No, I'm not sure I understand. Peripheral blood, is that it?
I don't know, it's just the initials.
Can you read it again? I can perhaps try to find it myself in the chat because I didn't really get the question.
It's from Olga at 5:45.
Okay, I can't see the chat. Is that normal?
And Olga said yes to your question about PB.
Okay, but what was the beginning of the question then?
Yeah.
Sorry.
It was, could be a pathology persistent number of eosinophils 0 in PB.
Wait a second. I still don't understand. I'm sorry if there's a problem with so Olga, could be a pathology persistent number of eosinophils 0. So do you mean that the question is, are there pathologies where the eosinophil count is persistently 0? Is that the question? If so, there's a nice article which was published many years ago with Gerald Gleisch as first author in Allergy, which scoured the literature for the rare cases of patients who had no eosinophils and peripheral blood counts. This is exceptional, and does not seem to be associated per se with any pathologies. Although in that particular very, very nice review, which you can go look, these were kind of complex patients who had other problems. We now have eosinophil depleted individuals who take Fasenra, so benralizumab, which is a very, very efficient eosinophil depleting agent. And it seems so far that it doesn't seem to be an enormous problem to have eosinophils at 0 for prolonged periods of time. I hope that answers the question.
Thank you, Florence. Now on to the next one by Virgilio. Is hypereosinophilia in hepatic fasciole is common in Peru? Chuck Strauss, formerly named, is molecular markers worth it?
So does that mean that, okay, so I understand the first statement. That's a comment, and it's true. Fasciola hepatica is certainly a cause of hypereosinophilia. I don't see the link with Church-Strauss, which is EGPA, so the disease I mentioned at the end. But it certainly is a diagnosis which is worth thinking of, suspecting in a patient who has asthma and hypereosinophilia. If you have pulmonary symptoms, specifically asthma and hypereosinophilia, you have to think about Church-Strauss, now known as EGPA. I'm not sure I answered the question, but I'm not sure I understand the question either.
Thank you, Florence. Now on to the next question, the last question, I think, as well, because it's 6 p.m. From Matteo Dragani. How often do you rely on molecular analysis like next generation sequencing or RNA sequencing in your diagnostic flowchart? Because for eosinophilic disorders, some relevant mutations are not part of routine myeloid lymphoid panels, and I struggle in my practice to demonstrate presence of mutations clonal origin in patients whose clinic presentation suggests an hematological disorder, i.e. splenomegaly.
Yeah, okay, so that's a very, very pertinent question, obviously, and I think that we'll be able to approach the answers partially in the following 2 webinars, which will be given by my colleague. But to answer the question in terms of my personal experience, so we do not do these kind of in-depth analyses like next generation sequencing for all patients with hypereosinophilia, which is idiopathic. But as you mentioned, if there's an anomaly which suggests that this could eventually be clonal hypereosinophilia, but we're not being able to detect it with the test that we use nowadays, I certainly do NGS. So far, it has not changed my practice. It has not added anything, but whether it's splenomegaly or the impression when you do bone marrow that the eosinophils are a bit dysplastic, or there seems to be something wrong with another lineage in the bone marrow, I would definitely go to NGS. But we're really here at the tip of what we know in terms of drivers of clonal hypereosinophilia. And I'm sure that my colleague would also have perhaps a more informed answer to give to that question. So I would encourage you to ask him as well. But my experience is that I personally do NGS in patients who have idiopathic HES plus one or the other marker, which makes me suspect it could be clonal, because that's going to impact the way I'm going to follow and the way I'm going to treat this patient.
Thank you very much, Florence. And now I think it's time to close the session. I want to thank you all, and for all your further curiosity and questions, I encourage you to join us on the next during the next session. Thank you very much to everybody who has joined us, and thank you very much, Florence, for your presentation and for the Q&A session.
Thank you for the interesting discussion.
Have a great rest of the day.
Yeah, you too. Thank you. I hope to see you soon. Bye-bye.